Welcome to the Rad Onc Smart Review Head and Neck Cancer series.
Glad to be here.
If you are preparing for oral boards, or really if you just want to achieve mastery in managing the head and neck patient, this session is for you. Today, we're doing a head and neck workup masterclass. We're going to focus specifically on those critical steps, the flexible scope, the strategic use of PET, panendoscopy, and the absolute necessity of biomarker testing.
Right.
Our mission today is really mastering the discipline of diagnosis in head and neck oncology.
And that word discipline is so key. It's the structure you apply during that diagnostic phase that, convinces your attending or an oral board examiner that you're not just capable of aiming a linear accelerator.
Right.
It shows you own the whole patient management pathway.
Exactly. Look, we know you're here because you can draw an IMRT plan. But when you're under pressure, the very first thing an examiner wants to see is that you have a predictable, a comprehensive structure for working up the patient.
And if you skip steps, you immediately signal clinical immaturity. It's a huge red flag.
It is. Which brings us to, I think, the foundational hierarchy, the anchor principle of clinical thought.
Diagnosis before staging, staging before planning, planning before treatment.
You have to be able to recite that in your sleep.
Oh, absolutely. Because if you start talking about Guy fractions while the primary is still occult, you've basically failed the test right there.
So to protect yourself, you need a prepackaged response. We call this the shield sentence.
It's your defense.
It is. It stops the examiner's leading questions, it demonstrates professional maturity, and honestly, it buys you a few seconds to organize your thoughts. It's a crucial skill.
So important. You have to practice delivering it calmly, professionally.
So let's say it goes. Before I discuss treatment, let me complete the workup. History and physical, flexible nasopharyngeal endoscopy, appropriate imaging, tissue diagnosis, and biomarker testing.
Just like that. Calm, controlled, and comprehensive.
Okay, so let's take that principle and apply it to a really high-yield scenario. I mean, this is the case that walks into every clinic on a Monday morning.
It really is.
It happens all the time. You have a 55-year-old male, history of 10 pack years of smoking. He comes in, he's got this painless growing mass in his right neck. On your exam, you feel a firm 3-centimeter mobile lymph node. It's in the right level 2 region. His oral cavity exam is totally unremarkable, no obvious lesion.
Right, nothing on the surface.
Nothing.
Yeah.
He says he has no trouble swallowing, no hoarseness, no recent weight loss. And he comes with a contrast CT of the neck, and it shows a 3-centimeter necrotic level 2 node. The report says no definite mucosal primary identified.
And here comes the trap.
Always.
The consult note or the examiner will ask, what is the plan for radiation?
And this is that critical juncture. The temptation for a trainee is to immediately start describing your IMRT technique, your dose constraints, your VMAT approach.
You assume it's just a standard unknown primary.
Exactly.
Yeah.
So why is rushing to draw fields here such a fundamental mistake?
Because you haven't established what you're treating. And if you don't know what you're treating, you can't possibly establish the correct target volumes. It's that simple.
Right. Radiation is all about margins and dose.
And both of those are dictated by the disease subsite and the stage. For example, if this turns out to be an oropharyngeal primary, your field might be very different than if it's, say, a skin primary.
Totally different.
So that structure diagnosis before staging, it says the resident. It forces you to methodically think through 3 common presentations.
Okay, what are they?
First, the classic one, a visible mucosal primary, maybe in a big tonsil tumor, with or without a neck mass. The workup there is to confirm the extent.
Straightforward.
Second is the case we just described. A neck mass, no obvious primary. This immediately kicks off the rigorous SCC of unknown primary workup.
Right.
And third, an incidental finding. A PET-avid node you find during lung cancer staging, or a suspicious parotid mass on a dental scan. In all 3 of those cases, you have to complete the steps. You have to define the disease before you treat.
That makes perfect sense. So for our patient, the 55-year-old male with that level 2 node, let's deliver that 60-second board script response. The one that shows the examiner you are methodologically sound.
You ready? Let's hear it.
This is a 55-year-old male with a right level 2 cervical lymph node, suspicious for metastatic squamous cell carcinoma from an occult head and neck primary, with the oropharynx and nasopharynx high on the differential based on nodal level and epidemiology. Before discussing radiation, I will complete a structured workup. A full head and neck history and exam, including skin exam, a detailed cranial nerve exam, and flexible nasopharyngeal laryngoscopy to evaluate sites not visible on oral exam. Imaging includes high-quality contrast CT or MRI of the primary and neck for anatomic definition, and FDG PECT for staging and occult primary detection, noting that PET-CT should be performed before invasive biopsies to maximize diagnostic yield. Tissue diagnosis begins with ultrasound-guided FNA of the node for cytology and cell block, with P16 and EBV testing as decision-altering biomarkers. If the primary remains occult after PET in clinic exam, I proceed to examination under anesthesia with directed biopsies and diagnostic palatine tonsillectomy, often with lingual tonsil sampling, because occult HPV-associated primaries may be submucosal within tonsillar crypts. Definitive treatment fields are determined only after primary site identification and final staging.
That is the perfect response.
Yeah.
It immediately shows you have mastery of the algorithm.
Yeah.
So let's break that down now, piece by piece. Let's start with the anatomy and the risk factors you just mentioned.
Okay. When you have a neck mass, the level is absolutely everything.
It's your first clue.
It really is. The location of that metastatic node is the strongest hint you have about where the primary might be hiding.
So let's start with level 2, which is our patient's presentation. That's the jugulo-digastric region. When I hear level 2, especially level 2A, my mind immediately goes to the oropharynx, the nasopharynx, and maybe the supraglottic larynx.
Yeah, and why there specifically?
Because the lymphatic drainage from the palatine tonsils and the base of tongue, which are the prime sites for HPV-associated cancer, it feeds right into that chain. So that location puts a huge spotlight on those hidden mucosal sites.
And how does that differential change if the mass is, say, in level 1B?
Level 1B is anterior, near the submandibular gland. That tells me to look anteriorly. I'm thinking oral cavity floor of mouth, anterior tongue, buccal mucosa. It completely steers my physical exam away from the back of the throat.
Okay, moving down, what if you see involvement in level 4?
Level 4, the lower jugular chain, shifts my focus down. I'm worried about the hypopharynx, subglottic larynx, thyroid, maybe even the cervical esophagus. It's all about that anatomical geography.
And level 6?
Level 6, the anterior compartment, is almost always thyroid cancer, or, much less commonly, a subglottic or anterior tracheal primary. The geography is not academic, it's how you prioritize your search.
Let's talk about level 5. That posterior triangle involvement is often a key differentiator, right?
It's critical. When I see level 5, I double-check the nasopharynx, because that's a primary drainage site for NPC. But even more importantly, I'm checking the skin of the posterior scalp and the neck.
The cutaneous primary.
Exactly. An aggressive cutaneous squamous cell can pop up in level 5 first. If you miss that little skin lesion on the back of their scalp, you've missed the entire etiology. And we should also mention the retropharyngeal nodes.
Right, the ones that are often forgotten.
Deep in there. Their involvement is a major red flag, highly correlated with nasopharynx and posterior pharyngeal wall primaries.
So beyond the lymph nodes, what are the mandatory anatomical sites we have to visualize?
3 sites are completely non-negotiable in an unknown primary workup. First, the fossa of Rosenmiller in the nasopharynx. It's a classic hiding spot for nasopharyngeal carcinoma.
You're looking for any subtle asymmetry or fullness.
Exactly. Second, the palatine tonsils and the base of tongue. These are the main hubs for occult HPV cancers. They can be tiny, buried in the crypts, which is why a tonsillectomy is often needed.
And the third?
The piriform sinus in the hypopharynx. It's a common spot for SEC, and it often presents late with just a mass or maybe some refer-to-your pain.
Okay, so let's move from geography to history. The risk stratification. This is structured data collection.
Absolutely. You start with tobacco exposure. You have to quantify it in pack years. And you need to know, are they a current or former smoker?
And why is 10 pack years such a common, sort of board-friendly cutoff?
Because the data shows that tobacco exposure worsens outcomes even in HPV-positive oropharyngeal cancer. So while HPV-positive disease generally has a great prognosis, you add 10 pack years of smoking, and that patient shifts into a higher risk category.
So our patient at 10 pack years is right on that clinical dividing line.
Yes, it makes the final pathology report even more critical.
Hmm.
Next is alcohol exposure. It's synergistic with tobacco.
Yeah.
You need to know their intake, but also their liver function, their nutritional status. Can they even tolerate chemo?
And then there's the biological context, like a history of immunosuppression.
This is a major differential shift. If a patient has had an organ transplant or is on long-term steroids, Their risk for aggressive cutaneous SCC just skyrockets.
So a level 2 node in that patient makes you think skin first, not mucosa.
Exactly. Your whole workup shifts externally. And finally, you have to ask about prior radiation.
A re-irradiation case.
Yes. Any prior radiation to the neck or upper chest completely changes the tissue tolerance. It fundamentally alters your dose constraints, your total dose. It's a completely different planning problem.
All right, let's move to the physical exam. This is really where competence is demonstrated. It can't be just a quick checklist.
No, it has to be meticulous. You start with neck palpation, be systematic, note the location, the size, the consistency, is it firm or cystic, and the fixation.
And fixation implies extranodal extension, right?
It does. It implies ENE and often bumps up the end stage.
Mm-hmm.
And the rule is simple. A persistent neck mass in an adult is malignant until you prove it's not.
And what about inspecting the mucosal sites?
A thorough oral cavity inspection is essential. Use a tongue depressor, visualize everything, and crucially, you have to do bimanual palpation.
Glove up and feel the floor of the mouth.
Yes, one finger inside, one under the chin. You can feel induration or deep submucosal thickening that you just can't see. Then you look at the oropharynx, tonsils, soft palate. Look for asymmetry. A little unilateral tonsil fullness could be your only sign.
Then there's the mandatory skin exam. We can't stress this one enough.
It is a mandatory board checkpoint because it prevents that classic, embarrassing miss of a cutaneous primary masquerading as an unknown primary.
You have to inspect the scalp, behind the ears.
The face, the ears, all of it. If you skip this, and the patient had a little skin lesion that healed over but already metastasized, you missed the entire diagnosis.
Okay, now for the component that really shows expertise, the cranial nerve exam. Why is documenting this so important?
Because it screens for advanced disease. Cranial nerve deficits are huge flags for skull base involvement or deep perineural invasion.
Let's run through them.
Okay. Cranial nerve 5, the trigeminal, facial sensation. If a patient has numbness in their cheek or chin, that's your clue for perineural invasion, PNI, running along the nerve. That means much wider, higher dose radiation fields.
What about cranial nerve 7, the facial nerve?
Facial movement. Unilateral weakness there is a major parotid clue, since the nerve runs right through the gland. It suggests a parotid tumor or deep lobe extension.
And the lower nerves for swallowing and voice.
Cranial nerves 9 and 10, glossopharyngeal and vagus. You check for palate elevation and voice quality. A weak, soft palate points to deep pharyngeal or skull-base disease. And then 11, the accessory nerve, the shoulder shrug.
This is more a baseline check, right?
It's a critical baseline. We're often planning a neck dissection or high-dose radiation right next to that nerve. You need to document its function beforehand, so any post-treatment weakness isn't a surprise.
And finally, cranial nerve 12, the hypoglossal.
Tongue movement. If the tongue deviates to one side when they stick it out, that is a major red flag. It points to involvement near the hypoglossal canal or deep in the neck. You're ordering an MRI of the skull base immediately.
Okay, now we move to the mandatory office procedure, flexible nasopharyngeal endoscopy. If you miss this, you are in big trouble on boards.
You are. It's mandatory because it lets you see the inaccessible sites, the nasopharynx, hypopharynx, larynx, areas you just can't see well with a mirror.
And beyond just looking, what is the single most critical functional finding you have to document?
Vocal cord mobility. That one piece of information can be a staging bombshell. If a laryngeal or hypopharyngeal tumor causes a vocal cord to become fixed, the T stage immediately jumps from T2 to T3.
And that completely changes prognosis and treatment options.
Completely. It dictates whether the patient is even eligible for laryngeal preservation strategies. You have to explicitly say you visualized the fossa of Rosenmiller and inspected both piriform sinuses.
All right, let's get into the imaging sequence. We have 3 main tools, and they serve different functions. It's anatomy versus metabolism.
Exactly. The CT neck with contrast is your workhorse. It gives you the essential anatomic definition: nodal size, necrosis, cartilage invasion, the extent of the disease. It's the structural map you use to draw your target volumes.
And when do you opt for an MRI instead?
MRI is superior for soft tissue.
Yeah.
So you use it when that's what's paramount. Suspected skull base involvement, deep spaces of the tongue base where you suspect PNI, and the nasopharynx. It gives you way better definition of submucosal spread than a CT.
And finally, the metabolic map, the PET-CT. How should trainees think about its role and, maybe more importantly, its limitations?
PT-CT has 2 main jobs: full body staging, so checking for distant mets, and occult primary detection. It's essential for finding that hot spot that guides your next biopsy.
But the limitation is key.
It's crucial. PET-CT is not a replacement for a high-quality contrast CT or MRI for local anatomic detail. The spatial resolution just isn't there. You can't define millimeter-level CTZ margins to the PTT.
This leads right into the mandatory discussion of PET timing. This is a huge board trap.
It is. The rule is simple. Get the PT-CT before any operative manipulation or mucosal biopsies whenever you can.
Explain the reasoning there. What's the analogy?
Think of the PETT as a map of high metabolic activity. Well, invasive procedures, a tonsillectomy, a deep punch biopsy, they cause intense inflammation as the body tries to heal.
And inflammation is highly metabolically active.
Extremely.
Yeah.
So that inflammation produces this intensely bright, false positive FDG uptake right where the surgery was.
So if you get the PET after the surgeon samples the tonsil, the whole tonsil just lights up like a Christmas tree.
Exactly. You've contaminated your metabolic map. You've obscured the true, subtle primary tumor with this blindingly bright false positive signal from the inflammation. So we do the PT first.
The only exception being the FNA.
Right, a fine needle aspiration is minimally disruptive. That's usually fine to do early.
Okay, let's talk tissue diagnosis protocol. The philosophy here is do not violate the neck.
Step 1 is an ultrasound-guided FNA of the node. It's the preferred initial test. It's quick, low morbidity, and usually gets you enough material for your biomarkers.
Why is avoiding an open excisional biopsy as a first step so incredibly important for us in radiation oncology?
Because an open biopsy can just wreck the normal tissue planes. It can spill tumor cells into the surgical bed. If that happens, we are forced to treat a much larger target volume.
A wider CTV, higher dose.
A much wider CTV, maybe a scar boost. It massively increases the risk of xerostomia, dysphagia, all the long-term toxicities. The professional move is to insist on FNA first.
Now let's integrate the biomarker logic, using biology to tell us where to look.
So P16 testing is the standard for oropharyngeal carcinoma. It's the surrogate marker for HPV. In an unknown primary setting, if that P16 comes back positive, it is highly directive. It points you straight to the oropharynx, the tonsils, and the base of tongue.
You assume it's an occult tonsil primary until proven otherwise.
You do. And for the other key biomarker, EBV, the focus shifts completely. EBV is the standard for nasopharyngeal carcinoma. If that's positive, you immediately redirect your attention to the nasopharynx, specifically the fossa of Rosenmiller.
We should probably also mention the role of EBV DNA in the plasma for NPC.
Oh, absolutely. Plasma EBV DNA is integral to NPC management. High baseline levels correlate with worse prognosis, and if the levels start rising after treatment, it's a very sensitive indicator of recurrence, often before you can even see it on a scan.
Now we need to stress the critical distinction here. This is another major board trap. You can't just treat P16 as a universal good prognosis marker.
That's right. P16 is decision-altering for the oropharynx because of that unique HPV biology. But if you find a P16 positive tumor in the oral cavity or the larynx, you do not automatically apply that favorable OPC staging or think about de-escalation.
Why not?
Because the biology is fundamentally different. In those sites, you treat based on the primary site guidelines. The P16 positivity doesn't carry the same profound prognostic weight.
Okay, so we've done the exam, the scope. The FNA is SCC, and it's P16 positive. The PT shows a subtle abnormality. What's the final diagnostic step?
Now, you proceed to examination under anesthesia or EUA with direct laryngoscopy.
And the sampling has to be very specific.
It does. For a P16 positive occult primary, the key high-yield step is a diagnostic palatine tonsillectomy. It has a much higher yield than just a superficial punch biopsy, and you often pair that with some lingual tonsil sampling at the base of the tongue.
Walk us through why a full tonsillectomy is better than a simple biopsy. It sounds like a lot for just a diagnosis.
It's all about the biology. These occult HPV primaries, they often start deep inside the tonsillar crypts. They can be tiny, microinvasive, and completely submucosal.
So a punch biopsy might just skim the surface and miss it.
They might only get benign surface tissue. The tonsillectomy gives the pathologist the whole specimen to slice up and analyze, which maximizes the chance of finding that tiny little primary.
Let's apply this whole algorithm back to our case. The 55-year-old male, 10 pack years, level 2 node.
We proceed methodically. Step 1. Ultrasound-guided FNA shows SCC. The cell block comes back P16 positive, EBV negative.
Okay, so our search is focused on the oropharynx.
Step 2. We get the PET-CT before anything else, and the result. An avid right level 2 node, plus a subtle asymmetric FDG uptake in the right palatine tonsil.
The PET found the needle in the haystack.
It did. Step 3, flexible scope confirms no other primary and, importantly, documents normal vocal cord mobility. Step 4, we go to EUA, we focus on that right tonsil, and we do a diagnostic right tonsillectomy.
And the result?
The pathology confirms a small, invasive SCC in the tonsil, P16 positive.
And just like that, the power of the structured approach is clear. The case is now a defined oropharynx cancer. We can stage it properly and finally talk about treatment.
But before we do, we have to touch on toxicity management related to the workup itself.
Right, it's not just about mucositis from radiation. The first one is post-tonsillectomy hemorrhage. This isn't a pediatric procedure. In an adult, especially a smoker, it carries a real risk of significant bleeding. We have to be aware of that.
And the second harm, the one we can and must prevent, is the neck violation from an inappropriate open biopsy.
We talked about this, if that happens.
We're forced to increase the size of our CTV. We might have to treat the whole neck, add a scar boost, and just fry the normal tissues, leading to terrible long-term swallowing problems. Owning the workup means actively preventing that from happening.
This whole structured approach, especially the focus on TIP16, it's built on a few cornerstone trials. If you're prepping for boards, you need to know these names.
The absolute cornerstone is the ENG study, New England Journal of Medicine, 2010. Before this, we staged OPC just on TNN size. This trial changed everything.
What was the specific finding that was so transformative?
ENG established HPV status as the dominant prognostic factor. It showed this dramatic difference in survival. For HPV-positive non-smokers, the 5-year overall survival was around 82%.
And for HPV-negative heavy smokers?
It dropped to a staggering 35%. I mean, that huge gap proved that biology trumps anatomy. And that evidence led directly to the separate HACC 8th edition staging for P16 positive disease.
Building on that, we have the Gillison study from 2012. What did that add to the picture?
Gillison provided the crucial evidence showing how tobacco interacts with HPV. It showed that even in the HPV positive group, adding heavy smoking, that 10-pack-year cutoff conferred a significantly higher risk of failure and death.
So it showed that synergy is real.
Very real. It's why that pack-year cutoff is still so clinically relevant for risk stratification.
And beyond the trials, we have guidelines that enforce this discipline.
Yes. The ASCO guideline for unknown primary lays out the algorithm we just walked through, and the AOHNS guideline on neck masses reinforces prioritizing FNA over open biopsy, guarding against that neck violation trap.
All of this enforces that mnemonic we started with. Structure leads to safety.
And to better outcomes. The entire goal of this whole rigorous workup is singular, to define the definitive targets for our radiation beams.
So once the primary is found, the tonsil SCC in our case, we can finally start defining the gross tumor volume, the GTV, the clinical target volume, or CTV, and the planning target volume, PTV.
Right. And identifying that primary fundamentally changes the CTV compared to a true unknown primary.
Can you elaborate on that difference? What does finding the primary actually save the patient from?
Well, in a truly unknown primary where everything is negative, we're often forced to treat this huge empiric mucosal volume covering basically the whole pharynx bilateral neck.
Just in case.
Just in case. It irradiates a massive amount of normal tissue. In our patient, finding that tonsil primary lets us tailor the plan. We treat the ipsilateral neck aggressively, but we can treat the contralateral neck prophylactically with a much smaller field.
Which means you can spare the contralateral parotid gland.
Exactly. And that is vital for long-term saliva function and swallowing. This is the practical payoff of that diagnostic discipline. And it's why you only determine your definitive fields and doses after you have the final stage. The sequence is paramount.
All right, let's transition to some high-yield learning tools. Let's synthesize everything we've talked about.
The mental foundation is that mnemonic. Diagnosis before staging. Staging before planning. Planning before treatment. Don't ever deviate from that sequence.
Perfect. Now let's run through our high-yield clinical pearls. I'll state the pearl and you give the context, the why behind it.
Let's do it.
Pearl 1. Before I discuss treatment, I complete the workup.
This is the professionalism test. It shows you think like an attending who owns the entire patient pathway, not just the treatment machine.
Pearl 2. Flexible scope is mandatory at initial evaluation.
2 reasons. Visualization of hidden sites and the mandatory functional check of vocal cord mobility, which is a staging criterion.
Pearl 3. FNA first. Do not violate the neck.
This prevents contaminating the surgical bed from an open biopsy, which forces you to use larger, more toxic radiation fields.
Pearl 4. PET-CT helps find an occult primary and stage, but it is not a substitute for contrast CT or MRI.
You need the PET for the metabolic map, but you absolutely need the high-resolution CT or MRI for the anatomic detail to draw your treatment margins.
And Pearl 5. P16 points to oropharynx, EBV points to nasopharynx. Biomarkers tell you where to look.
Right. This is a geography of biology. Use the biomarkers to guide your surgical sampling.
Excellent. Now for our board blitz. 4 quick oral board-style questions.
Our way.
Question 1. In an adult with a persistent level 2 neck mass, what is the preferred initial method of tissue diagnosis? A. Open excisional biopsy. B. Ultrasound-guided FNAC, immediate neck dissection. Or D. Panendoscopy first.
The answer has to be B. Ultrasound-guided FNA. It's safe, efficient, and avoids neck violation.
Question 2. In metastatic SCC with no visible primary, which biomarker most strongly directs your search to the oropharynx? A. EBV positive. B. P16 positive. C. Tyrosine kinase receptor positive. Or D. Immunosuppression history.
B. P16 positive. That's the clearest biological signpost pointing you to the tonsil or base of tongue.
Question 3. The sequencing trap. Which principle best preserves the diagnostic value of PECTA, PET after tonsillectomy? B. PET after deep biopsies. C. PET before operative mucosal biopsies. Or D. PET is unnecessary if MRI is negative.
C. PET before operative biopsies. You have to avoid those false positives from post-procedural inflammation. Preserve the metabolic map.
And a rapid recall drill. Why tonsillectomy instead of a punch biopsy for a P16 positive unknown primary?
Because the occult HPV primaries are often submucosal, hidden deep in the tonsillar crypts. Excision increases the diagnostic yield dramatically.
Great. Let's finish up by focusing on the major pitfalls, the 3 common board traps.
Trap 1 is jumping to treatment. If your first response is to describe an IMRT plan before you've laid out the full workup, you fail to show command of the patient's care.
Trap 2. Getting the PET-CT after you've manipulated the mucosa.
You generate confusing false positives, and you basically destroy the value of the study for finding the primary. It's a critical sequence failure.
And trap 3. Treating P16 as a universal de-escalation marker. Let's dig into this controversy.
Right. While P16 is incredibly powerful in oropharynx cancer, you cannot generalize that better prognosis treat less narrative to every subsite.
So a P16 positive oral cavity tumor is a different beast.
A completely different beast. You treat it based on its local staging and the guidelines for oral cavity cancer. HPV in those sites is often just a passenger, not the primary driver. You have to respect the subsite specificity.
That's a fantastic point. Knowing the limits of the data is just as important as knowing the data itself.
So this whole masterclass, it really focused on discipline. Sequence matters more than almost anything else. We started with a confusing neck mass, and by applying a strict, evidence-based algorithm, we got that patient to a defined, stageable HPV-positive oropharynx cancer.
So to recap for everyone listening, sequence matters diagnosis before staging. Flexible scope is mandatory. FNA first to avoid neck violation. PECT timing is crucial. Get it before operative biopsies. And finally, use P16 and EBV to let biology guide your search.
The goal is to sound like a professional who owns the entire workup. That's the maturity and methodological soundness you want to project.
That is the ultimate goal. Well, thank you for tuning into this session. For complete practice oral boards and more deep dives, visit radoncsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode in the Head and Neck series.